the Q&A box, and we will address as many questions as possible at the end of the webinar. And as a reminder, this is being recorded. We'll start with some introductions, and we'll start with Lynn Grant. Lynn, turn your camera on so we can see you. There we are.
Hi, I'm Lynn Grant, and I'm a clinical nurse specialist. I graduated from UCSF a few years ago, many years ago, and I work at Stanford's Advanced Wound Care Center in the San Francisco Bay Area. And I've had a lot of experience with wound care and speaking with both Foy and Lisa for the Wound Healing Society.
And Foy, who are you?
Hi. So I'm Foy White-Chu. I'm a geriatrician and wound healing physician in Portland, Oregon. I'm an associate professor at Oregon Health Sciences University and the medical director of our wound healing program here at the Portland VA. I'm the chair of the amputation prevention team, and I also have had a lot of experience working both with Lynn Grant and Lisa Gould on various projects with the Wound Healing Society. Real honor to be here today. Thank you. Lisa, you're muted.
Let's try that again. Hi, I'm Lisa Gould. I'm a plastic surgeon who has dedicated my entire career to taking care of difficult wound problems. Just finished debriding one in the operating room and fixing a vac, and I'm happy to be here. I was one of the original participants in wound scene investigation, so some of these patients were mine, and we're really excited to have this as our last wound scene investigation webinar before we move on to another project for the education committee. And I am going to start my sharing my screen. Make sure I have the right one. Okay, and let's see if I can get, gotta hit slideshow. There we go. Okay, so this was a presentation in 2017, and it was about some of the zebras that we see in wound care, as well as some of the horses. But I have the honor of talking about the zebras today. And when we say zebras, it doesn't mean that you won't see them, particularly if you are working in a specialized wound center with referrals, but they are not the most common things. And we're not covering all the zebras. We're just covering a couple of them today. Let's see. There we go. So the first one is Chondrodermatitis nodularis helices, and it is definitely a zebra, usually abbreviated CNH. And it was first described in 1915 by Max Winkler. It's usually associated with pressure can be from hearing aids, headphones, mobile phones. There's some suggestion that it might be an autoimmune disease. And I have a series of 3 patients, and they're all, surprisingly, they're all women, a 72-year-old woman, 66-year-old, and another 70-year-old, and they were all referred after they'd had months of pain. They had ulcerations, and they'd already been treated with topical wound care, and some had had steroids, and there was no improvement, and there was no unifying systemic illness that we could put together to say why they would all have this problem. And they all tend to lie on the affected side, placing pressure on that ear. So we have to think about what the differential diagnosis is, and what does it look like? It really doesn't look like anything except a pressure ulcer, but a diagnostic biopsy in all 3 showed Chondrodermatitis nodularis helices. And so what they're looking at is the cartilage. They often present with a rounded nodule with raised edges, like the one in the 72-year-old, maybe crusting in the center, and they may have exposed cartilage, which is very difficult to heal. And all of these patients had topical steroids, they had systemic steroids, at least one of them had intralesional steroids and nitro-paste with no response. And they're very inflammatory wounds and very painful. The exact cause is unknown. There's studies that suggest that it's prolonged and excessive pressure. And for those who have taken care of patients with ear lesions or have operated on the ear, you know that the ear really doesn't have much subcutaneous tissue, and there's no insulation or padding. The small dermal blood vessels supply the epidermis, the dermis, and the perichondrium, as well as the cartilage. And so when there's damage, it doesn't take much to get an ulceration and a wound that's difficult to heal. So there's, it may occur from inflammation or edema or necrosis from either trauma. It could be from cold, and apparently sun damage can also initiate CNH. Usually people start with medical treatments. As we said, these patients all had topical steroids. They had systemic steroids and nitro paste in order to dilate the vessels. But the surgical treatment is to remove the inflamed cartilage. So one of the things, I mean, you see it so rarely, how do you even do research on it? But the questions we ask ourselves is why, if it's from pressure, why don't they heal when you offload the pressure? You would think that they would, and they really don't respond the same way as your typical pressure ulcer. But is that because there's so little subcutaneous tissue? We don't know. Now, recently, we've seen more pressure injuries of the ear during COVID, and most of those healed once you remove the offending area. Sometimes it was the oxygen tubing or the straps from our masks that were causing the pressure ulcers, and they get better when you remove that. Another question that we ask ourselves, and I don't know that we have an answer, is what is the difference about inflammation of the cartilage as opposed to inflammation anywhere else? The cartilage is very poorly vascularized, and so probably doesn't get the same inflammatory cells to it, and therefore may have a subnormal inflammatory response, whereas we're used to chronic wounds that have an excessive inflammatory response. And then from a surgical point of view, it's really hard to determine how much cartilage to remove. If there's a nodule, it's obvious, but you really, visually don't see inflammation in the cartilage. So we can elevate the skin and get down to the cartilage and then try to figure out whether it's thicker or has some sort of inflammatory response around it to remove it. So in this case, these patients had all their topical and other conservative treatment. So we moved straight to surgical treatment, and they all had surprisingly immediate relief of their pain after excision of the skin and the cartilage. So I guess, even though we can't see it in the cartilage, we're removing that inflammatory material that we know invokes the pain response, and the pathology confirmed CNH in all three. I always send the tissue for pathology, no matter what I take out, because I've been fooled several times thinking I had the diagnosis and I didn't. And then, going back to the differential diagnosis, whenever there's a wound that isn't healing, particularly on the ear, because it's a big area of sun exposure, we have to think about skin cancers. It could be a gouty tophus, and it could be a keratoacanthoma. Those would be the most common things in your differential diagnosis. But always, if you take a piece of tissue out, send it for pathology, and that way we can learn more and you might get the right diagnosis. So although the one on the left still looks inflamed, her pain was relieved and she went on to heal uneventfully. Here's another zebra. Pseudoepitheliomatous hyperplasia. It may not be quite as much of a zebra as we think, because we may not diagnose it very often, or it may be up to your pathologist. I have my suspicions on that. And our case today is an 88-year-old who presented to the wound center with a 4-month history of an open ulceration of the lower leg. This started originally as a blister, and then it opened up and it grew larger. Her arterial Dopplers revealed normal arterial flow, and then she had conservative topical treatments with no improvement. And a biopsy was performed after there was no improvement, and that showed, we abbreviated PEH, Pseudoepitheliomatous Hyperplasia, with no evidence of malignancy. So always when there's a wound that isn't healing according, and you feel like you're doing all the right things, you've done all the studies, it's good to get a biopsy. Sometimes it's to rule out something, sometimes it's to rule it in, but always looking for a malignancy, because I see a lot of those. So this is what the wound looked like over time, and with the topical treatments, and you can see it kind of changed in character. There were 2, and then this one on the right lower is a close-up after some more topical treatment. It can be very, very painful as well. And you can see that there's this big inflammatory reaction around the area. There are different PEHs. Primary is gingival PEH, which I've actually never seen. Secondary is due to chronic irritation or trauma. And again, you have to think of your differential diagnosis. But what's interesting is that PEH can come from tattooing, and also as a response to Mohs surgery and to other irritations. Again, you want to keep in mind that there's a differential diagnosis, because this lesion mimics malignant lesions. So always be thinking of a squamous cell, keratoacanthoma, could be a granular cell tumor, or a melanoma, or a verrucous carcinoma. It's unknown if PEH actually has a malignant potential. Can this progress to malignancy? And so that's why people tend to excise them when they can. Oh, and there is all the things that we talk about. So it really does closely mimic a squamous cell carcinoma. And so that's what has driven me most of the times to cut these out. But it's the pathologist will see a hyperplasia of the adnexal epithelium and the really hyperplasia of the epidermis. And I guess it's really, I see it in wounds. And the reason I said we may see it more often than we think, or it may depend on your pathologist, is because I rarely got the diagnosis. And then when I switched locations and had a different pathologist and did biopsies of some of my chronic patients with chronic wounds, I was getting that diagnosis back fairly often. So I think there's certain characteristics that pathologists look for. Others may not agree. So they don't really have a classical grading scale that says that this is definitely PEH. So it may depend on your pathologist whether you get that diagnosis or not. But basically, you're ruling out a skin cancer because this is a benign condition, and nobody has shown that really proceeds to be malignant. What's interesting is tattoos can cause PEH, but recently it's been shown that red tattoo ink can lead to cutaneous malignancy, and rarely it's also been shown to lead to PEH. And I found that interesting because it wasn't that long ago that I heard that in either Amsterdam or Finland, somewhere, they were outlawing red tattoos, and it may be because of that. I never really found the explanation for that. Whoops. Yep. So that is the end of the zebras. If you see them, you'll remember them forever. But if you don't, just always keep that index of suspicion for looking for zebras rather than horses. But now we're going to have Lynn talk about horses, and I'm going to bring up Lynn's slides for her.
Thank you, Lisa.
And we'll go from the beginning. There we go. Oh, I have to change my screen too. Hold on. Let's see. See if that worked. Lynn, are you there?
I am.
Okay. Let me see. Oop, sorry. Go back up there. I'm trying to figure out where my mute is. Now that I'm sharing my screen, I'm stuck. Hmm. No, we don't want subtitles. Oh my. No. All right, we'll just have you go ahead and I'll be very quiet.
I can't see my screen.
Oh,
I don't know if anybody can see the slides.
you what?
I don't know if anybody can see the slides.
They're not
No,
being
Lisa, we
shared
can't
right
see
now.
your screen.
Oh, sorry.
They're not being shared. Okay, let's see if we can figure this out. I should be able to get out of here. Let's see, end show. Okay, we're gonna end the show. I'm gonna put it there. And I am gonna get rid of my video. And let's see.
There we go.
You can see it now?
Yeah.
Okay.
So I'm going to continue on with unusual wounds from zebras to horses. And my talk is about a horse, hypergranulation tissue, and sort of in the spirit of the original wound healing scene investigation, where when they were given live at a combined wound healing society and symposium on advanced wound care conferences, you have to picture a very packed room towards the end of a conference with a lot of people in the room and a lot of noise. And so they started with a quiz. So we will start with a quiz. So what is Proud Flesh? Is it a German rock band, a 1925 film directed by Kind Vidor, an excessive formation of granulation tissue, or an episode of Law and Order Criminal Intent? I'm sure, as you all know, it's an excessive formation of granulation tissue. So hypergranulation tissue, also known as proud flesh or overgranulation tissue, is really an excess granulation tissue that fills the wound bed to a greater extent than is required. The tissue goes beyond the height of the wound surface, resulting in raised tissue mass and therefore impairing epithelial migration. So why are we going to talk about veterinary treatments? Well, horses heal differently than humans. They heal by granulation tissue rather than contraction. And so in that case, because of that, they have a lot of episodes of hypergranulation tissue. So there's several treatments. Wonder Dust is one of the more populars. It contains iodoform, potassium aluminum, and activated charcoal. And the real problem with this is in its name, dust. So if your animal breathes the dust or the human applying it breathes the dust, it can cause respiratory problems and cardiovascular problems. So something to be used with caution. PF, the Wonder Salve, has a secret formula that's enhanced by iron chelated silver. It's thought to be antifungal, antibacterial, antiviral, and anti-inflammatory. Equade is a unique formula, again, proprietary, antibacterial, and anti-inflammatory. And Proudzoff is 49% copper sulfate. So what was interesting in doing this project is that you also read a lot of anecdotal accounts that use all these products from the inception of the wound to the healing of the wound, and they do every manner of wound healing, much like new products we read about today. But it was interesting to hear the naysayers, right? Topical steroids do just as well as any of these products. So what about humans with hypergranulation tissue? When we see that kind of wet edematous, raised hypergranulation tissue, we typically think of bacteria. If it's kind of a dense, very friable looking, it's usually too much moisture. And in my experience, in many years of doing wound care, I've found that if you can catch this hypergranulation tissue at the very beginning and maybe look at topical antimicrobials, do a culture, maybe systemic antimicrobials also, or look at really what type of a dressing you're using. If there's too much moisture, you may be able to just, without any further treatment, kind of get rid of the hypergranulation tissue without going into any really extreme treatments. So what about those hypergranulation tissue that you don't catch early enough, somebody who's resistant to treatment? In this particular case, the clinic was presented with a 76-year-old who had a hematoma as an initial injury. And by the time it came to the clinic, had an infected wound with hypergranulation tissue. There was aggressive debridement, allografts twice, split thickness skin grafts, and cultures showed Actinobacter, Klebsiella, Enterococcus, and the wound never completely healed. And that was despite giving culture-guided topical and systemic antibiotics. Later cultures showed methicillin-resistant Staph aureus and Proteus. And you can see a little bit of improvement, but again, no real healing completely. So this patient recurred, change of approach. And you can see the difference with 1 week of topical steroids, a considerable improvement of the wound, which then went on to heal. And despite new cultures with Staph aureus, hemolysis, the wound cultures were not treated, no systemic or topical antimicrobials. So it just goes to show that sometimes if you just treat the hypergranulation tissue, the wound will heal. You don't always have to treat a positive culture. So what about all this hypergranulation tissue and proud flesh? A lot of the surgeons and a lot of the surgeons I work with are taught to treat with cautery by silver nitrate. And what does this do other than cause a lot of pain? Well, it does break down, it does decrease the hypergranulation tissue. It's thought to decrease the bacteria with the topical silver killing it off. But it's interesting that a lot of surgeons are very reluctant to use steroids on wounds because you're taught steroids decrease wound healing. And so it seems counterintuitive to put steroids on the hypergranulation tissue, but we're going to talk more about that later. And then, is there any merit to the veterinarian treatments? Well, if you looked at some of the ingredients of all those products that I talked about, there was copper in them, activated charcoal, chelated silver, iodoform. So all topical antimicrobials. So again, may have a bearing on the effectiveness of the veterinarian treatments. What does ultrasound do? Well, when I was researching the literature, I found that mostly ultrasounds would be done in the OR unless you have the capability of doing missed ultrasound in your clinic, and that really there wasn't any good literature on the treatment of hypergranulation tissue that I could see, because mostly they talked about how ultrasound helped increase granulation tissue. What about laser therapy? Well, pulsed dye laser therapy was definitely in the literature. 1 to 2 treatments tend to reduce the hypergranulation tissue and lead to healing. The problem with that is very few people have laser therapy in their clinics, so the patient will need to go to the OR for that procedure. Steroid therapy, definitely the most literature out there, lots going on. The most common topical steroids seem to be clobetasol. hydrocortisone acetate and hydrocortisones. And those were put either directly on the wound or put into impregnated into a gauze or wound veil and then put on the wounds themselves. And we're going to discuss a little bit more about that later. So overgranulation tissue, in the original presentation of this was sort of one of the landmark booklets, literature out there, put out of the Wound Care Alliance in the UK, and it talking about overgranulation tissue being caused by infection, inflammation, and friction. And I think the friction piece is really important to note here, because the friction that we're talking about typically is caused by suprapubic tubes, PEG tubes, G tubes, that kind of proud flesh you get around all of those, and how do you treat those? And that's really not in the wound healing preview, but most of those are done by topical antimicrobials and chemical cautery treatments. So what about hypergranulation tissue and antimicrobial dressings? They help. Again, I think in my experience, not once you have really thick hypergranulation tissue, but the methylene blue, gentian violet based foams, antimicrobial foams work. Then there's the silver dressings that come in foams, alginates, hydrofibers. And I think the gels are useless in hypergranulation tissue because it just adds more moisture to a wound you're pretty much trying to get moisture out of. And so you're going to pick your topical antimicrobial depending upon which bacteria you think is in a wound, and also looking at the characteristics of the wound and matching them to the dressing. And so that's really what you want to do for those. And then there are some of the iodine-based dressings that come both in a cream or a sheet form. So those can all be used as topical antimicrobials. And does chemical cautery work? Other than being painful? Yes, it can. And it's used, I would say, a fair amount in our clinic, a lot because we have lower extremity ulcers with patients who need compressions, and the physicians I work with feel very strongly that they're afraid that the steroids only put on once or twice a week won't work. Although when talking to Dr. Gould before this presentation, she finds it's totally efficacious to only use the steroids once or twice a week under compression, and it does take care of the hypergranulation tissue. But you can see it did work in this case, and this was a week apart. So that was the hypergranulation tissue, the chemical cautery, and definitely improvement in the wound. And again, in this wound, 2 weeks apart, again, you can see improvement in the wound with chemical cautery. And I do want to caution you, if you are using this type of treatment and you haven't put enough lidocaine on the patient and debrided, if you debrided them first and debrided all the lidocaine off, you may add some more topical lidocaine before you do the chemical cautery. And then for patients, families, home health, remember to remind them that the wound is not necrotic, that will peel off, so the dressings will have black and gray in them. Really do a lot of good patient education and family education with this type of treatment. So what is the etiology of this wound? Is it hypergranulation tissue? Is it pyogenic granuloma? Is it a malignancy? And I just want to pause here because this is not a malignancy. And unfortunately, I was not able to get the picture I needed of a great lower extremity wound that presented as a crossover between a pyogenic granuloma or hypergranulation tissue in our clinic, and we treated it with chemical cautery, and the patient came back a week later with absolutely no improvement. And after 2 weeks of that, we did do a biopsy, and it was squamous cell carcinoma. So I want, again, emphasizing what Dr. Gould had emphasized earlier, really look at wounds that are chronic, have a high suspicion of other underlying problems, and test and biopsy for malignancies. So this was a pyogenic granuloma, and those are benign vascular growths presenting as a friable red papule or papule. They're usually on the gingiva, finger, lip, face, or tongue. And sometimes in the literature, they're abbreviated as PG, so do not confuse this with pyoderma gangrenosum. And again, just rule out other causes. So how do you treat this? You can do surgical removal, electrocautery, cryotherapy, pulse dye laser treatment, intralesional sclerotherapy. But interestingly enough, because all those are painful and a lot of these are on the lips of younger children, they've done a lot of more treatment using salt therapy, table salt therapy, because the families can do it at home, and often they'll just do the cryotherapy or electrocautery once and continue on with some other therapies and have gone on for complete healing. So in summary, how do we treat our hypergranulation tissues? Well, I think if you look through the literature and think about the pain you may be causing patients, and some patients actually don't want to come back to your clinic, it's so painful. So you really have to be careful who you do chemical cautery on. Antimicrobial dressings, I do feel have a very, they're helpful, but they're not going to be your first line of defense. Pulse dye laser treatment obviously works, but again, the patient has to go to the OR for that treatment, so it's typically not the most feasible. Steroid therapy, as much as a lot of physicians may be resistant to use, if you look in the more recent literature, has definitely got the strongest background to use. There was one study where they looked at 350 cases out there, were only able to utilize 6 of those cases as feeling strong enough case studies and sort of general literature review to look at how they treated patients. And they did it from the years 203 to 219, I do believe, and found out that when they looked at steroid treatments, again, the 3 I cited were the most common, that the wounds tend to drastically improve to go to complete healing with very limited side effects. Only one study out of the 6 had side effects, and that was in a very small percentage of patients. They had scarring of the hypergranulation, and a thinning of the hypergranulation tissue and thinning of their tissue. Mm-hmm. And absolutely in all those studies, not one patient had a wound infection, which is often the concern in using steroid therapy. And then another study, chart review done in a Midwestern burn and wound clinic. They did a QI project, and what they did was they looked at the past year of treatment, and they randomized the patients were either treated with silver nitrate or they were treated with steroid therapy, and they compared wound decrease in size. And there was a significant difference in the steroid treatment group versus the chemical cautery group. And so then a year later, they did the same thing. They went back for a year, many more patients. The first time they looked for that first year, more patients were treated with chemical cautery than steroids. They presented their findings. In the second half, the second year of the QI study, they found that many more of their patients, over twice as many, were treated with steroids versus the chemical cautery. And again, a dramatic difference in wound healing and size decrease with the steroid therapy. So the take-home message from this is probably for the treatment of hypergranulation tissue, steroid therapy is the best. And now we'll entertain questions.
Thank you both. That was great. I have some questions, but I want to see if the audience has any first. You can utilize the Q&A area.
I'm gonna mention that if you look at some of those hypergranulation pictures, right, there's a really, really large area, and you could see how wet it was. That would be very difficult to treat with chemical cautery. So I think that that's one of the reasons. The other thing about the steroids is to really, the differential is it too much bacteria? So is it hypergranular because it's and you know, we're on this new scale now. You can't call it critical colonization, but it's essentially not quite infected, but too many bacteria. So you have this robust wet response, or is it an inflammatory response? And that's why the steroids work, is because it's you have a robust inflammatory response that you're trying to decrease. But it is a hard sell.
It is.
Well, and I think it highlights like what you were saying, you know, Lynn, you mentioned like, I'm guessing these were culture swabs that were done at the time. How, you know, excuse me, we know that some of those swabs can be problematic, but regardless, there's going to be bacteria there. So when you do these, are you, you're doing the steroids and then are you doing an antimicrobial on top of that? Dressing, I mean, antimicrobial dressing, excuse me, not a cream.
Lynn?
We use very few steroids, but we don't. It was interesting. So in the literature, in 2 of the reviews that I read, one of the original 6 that I talked about earlier, only one of the people had a combination of a steroid with gentamicin. And then in the second one, kind of they did their whole literature review. It was a hospital in Australia and it was a burn unit, and they did that big extensive literature review, and they used something called Kenacomb, which is a steroid mixed with nystatin, neomycin, and a couple, so another thing, but they said their take-home message was with the plain steroid treatment and not having any wound infections occur with just a plain steroids, they felt like a really good clinical trial would be to test their Kenacomb, which is a steroid with antifungal and antimicrobials, and a plain steroid would be a great research study. But again, it's like all wound, it's really hard to get these studies going. So everything I read was a retrospective chart review. But again, they weren't finding bacteria is a big issue. So that's what's really interesting. And to Lisa's point about those big leg wounds, you really want it. That's when you really are going to impregnate the steroid into a gauze or a veil type dressing, put it on the wound, because you'll never, it'll be too cumbersome to get all over the wounds themselves. And plus, whether you use a cream or an ointment, it's really hard to spread on a moist surface.
We got some great questions coming in. First one from Diana Boston. What about curetting the hypergranulation tissue, obviously after lidocaine?
So in our facility, we always do debridement first. And then then our doctors will do chemical cautery. And I suspect Lisa may do the same and then do her steroids.
Yeah, so sometimes you get these weird polyps too. That's a hypergranular response, and I'll cut those off and cauterize the base. And I have also used the topical steroids, say in the deeper wounds where it's super, you know, I've tried the topical antimicrobials and it's just not going away. And then I'll use steroids for a week and then they come back and it's flatter. And we've talked in other sessions about epithelialization, and the epithelium just doesn't like to grow up a hill, right? So it'll just,
I describe them as lazy.
Yeah, and you can't get it to reepithelialize until you conquer that height of the granulation tissue, and it's flatter, and then you'll see it. And you know so we're looking at our visual cues, but what's the actual mechanism that's going on? And I would suspect it's too much inflammation that's impeding the cell migration, but we don't know for sure.
And I want to get to Jeffrey Davidson's question, but before that, you were kind of getting to that from Margaret Edieri. They were talking about any suggestion for narrow and deep ulcers, so depth greater than 3 centimeters. That's pretty darn deep, but with excessive hypergranulation. So how would you approach that? I think you were getting to it.
Yeah, I mean, kind of the same thing. If it's a if it's really high hypergranular and it hasn't responded to the antimicrobials, I give it a try, but I do it with great caution. So I will bring the patient back sooner than I otherwise would, because I am concerned about infection. And I might start out slowly, maybe twice a week and see how it's responding. But really with a heightened awareness that it may be because the wound is infected and not because it's excessively inflamed.
And Jeffrey Davidson has a great question on a more micro level. Is the hypergranulation leading to suppression of normal progression of epithelialization? Is it a failure to undergo transition into neodermis?
I wish I knew.
Good question.
I mean, it needs to be studied a little bit more. It sounds like we haven't necessarily done a sufficient amount of those more bench micro looks of exactly what's going on at the hypergranulation level. Is that what I'm understanding?
Right. Well, in that one slide where you had 4 photos, and so it went across the top, and there was one where it was black from the chemical cautery, and then down lower, and then you could see the epithelium filling in pretty rapidly. Those were a week apart. So perhaps Jeff is onto something, that there's something in that hypergranulation tissue that is feeding back and inhibiting the epithelium from migrating.
Diana Boston made a further comment saying that they don't use chemical cautery for their hypergranulation, but found great results with curette and then using a gentian violet methylene blue foam under compression even better. So definitely addressing, I think, some of that bacterial burden that Lynn Grant referred to earlier, right?
Mm-hmm.
But I would say that in our clinic, with the methylene blue gentian violet dressings, there's resistant hypergranulation tissue. You're going to have to treat with something besides just that. At least we certainly see that because we use a lot of the methylene blue gentian violet dressings.
Mm-hmm.
Just a reminder, you can't use steroids forever. Like this is not something, typically in all the chart reviews, steroid treatment was about 2 weeks max.
Okay.
Yeah, because you will thin the epithelium, and then they'll get wounds over and over because they're so fragile.
I was already thinking about a patient that I've been struggling with, really large abdominal hernia. You can see the peristalsis at the superficial surface of the skin. He has venous stasis changes of his abdomen. And then he'll have these really thin areas, but they are that globular hypergranular. And I'm like, you know what? I haven't tried steroids. I think I'll do that the next time I see him and see how that goes.
Yeah, that's one where it's also, if they have a hernia, it's also the repetitive trauma. And we see that they keep ulcerating over and over because of breathing and coughing. And, you try to put
pressure.
in. Yeah. It's difficult to treat those.
I want to bring it back to the PEH because I find that really fascinating. Are there certain physical characteristics? You highlighted some of the areas around your wound that looked inflamed, but I'm kind of curious if there are other characteristics, like what would maybe tip you off, like, is this PEH? Is it certain areas of the leg? Is it only the leg? Or other characteristics of the wound itself that might be more typical?
Yeah, the ones I've seen have often had some crusting, and also pain. When, chronic wounds, usually the pain goes away. And when it didn't, that just in my experience and what I've read is that it's a painful condition. And so then we do the biopsy and that's when we get that result. Another thing about biopsies, they frustrate me because so often you get a negative result. You get, the what you hear from the pathologist is acute and chronic inflammation. It's like, well, that doesn't help me much. But Alex Ortega-Loaiza gave a talk also about unusual wounds I think it was last year at SAWC or maybe a year before. And he's a dermatologist. I'm no expert at biopsying, but I think the dermatologists are. And he even said they get about a 30% response or return on the biopsies. So they tend to keep biopsying. Whereas, if I biopsy it and I don't get what I'm looking for, I tend to quit. But one thing to remember is that, especially with malignancy, a negative result doesn't mean that it's not. It just could be a sampling error.
Exactly.
So if you still have you go back and you treat based on your biopsy and it's still not going away, think about rebiopsying.
Does it tend to be rapidly progressive necessarily? Like, does it it starts little and it just takes off,
No,
or
just kind of smoldering.
No, that one leg wound,
yeah?
we couldn't get him into derm for even after we had the positive squamous cell. So we were treating him for weeks after. Just kind of stayed the same. Just, but again, squamous cell is a lot underneath. And so you just see, so you don't know what's happening underneath and how far it progressed.
Right.
And he just went into surgery last week. So I don't know the outcome, or I'd let you guys all know, but it's just something I think it really, really looked like your typical hypergranulation tissue. Had a trauma, had the wound for months, been to different doctors, finally got to our clinic. And, it just looked like hypergranulation tissue, and nope, it wasn't. So, and our dermatologist a lot, because we do a residency where they follow us in our wound clinic one day a week, they tend to biopsy multiple, like when we're biopsying, we're like really kind of gingery, and they biopsy and then they suture afterwards. Like our doctor, they never want to have to suture and make somebody bleed. And so I've noticed that they tend to do a couple different sites, and so I think sometimes in our wound clinics, we're a little bit not as aggressive as we should be about our biopsies for true ruling out things.
And you're getting this biopsy from, go ahead.
I said maybe one day we should do a course on how to biopsy wounds.
It would be really
well, yeah, because we definitely talk about getting a biopsy from the edge, right? While deep tissue would be from, so I wanted to emphasize that as well. I just saw a gentleman yesterday with unusual foot wound, and you're right. I was like, which side looks the weirdest? I'll biopsy that side, right? Yeah.
Well, if there's no further questions,
sorry.
We know it's a little shorter than usual, but that's because we don't see a lot of zebras. And we also wanted to wrap up and thank everyone for attending the Chronicles of Wound Scene Investigation series, brought to you by the Wound Healing Society Education Committee and the Wound Healing U. And as a reminder, the recording will be available if in your member-only account on the Wound Healing U in the next few weeks. And this concludes our whole series of webinars, and we hope to see you at National Harbor for the Wound Healing Society annual meeting later this month.
And I also want to emphasize that many of our other previous presentations covered other zebras like vasculitis pyoderma. So please feel free to review those, and you can see other zebras as well.
Okay.
Oh, there was one more. Wait, I'm so sorry.
Thank you.
Oh, thank you. Okay, thank you.
Thanks for joining us.
Bye.
Bye.
Bye.